request of the meeting organizer, this meeting is being recorded.
To our February Partners in Care Roundtable on MSM of Color Health. We're really excited to bring you this program today, and we're sorry we weren't able to bring it to you yesterday, but as already noted, it's an important topic and an important group of folks for us to think about in serving well. And it's important that we have this discussion with all of you and not just have a small group recorded and kind of put it out there. A lot of the value here is by having all of us at the table to discuss MSM of color and how we can all serve them better together. So thank you very much for your understanding and patience, and thank you very much for joining us today. Before we start, one of the things I'd like to do is to have folks on the line enter a little bit about themselves in the chat room. This is helpful for folks who are new to joining this type of webinar and gives us a sense of where folks are calling from around the country. So I'll start. I'm Michael Hager, NQC, New York, New York. And disparities leader. And if you don't see your chat, chat module, you can, in the upper right corner of your screen, click the gray button that says chat, and then you'll see a new window appear where you can enter your information. Okay, so while I'm seeing folks entering in the chat room, I'm going to go ahead and move to the next slide. So just a couple of ground rules. We do have a small enough group today that I don't feel the need to mute all lines, but I will mute all lines if it's hard to hear or if there are any distractions. We ask that you avoid putting us on hold because you might have some groovy on hold music that could distract us if we're trying to have our conversation. And just in case we end up taking folks off of mute, it is very distracting. So try to put us on mute instead of putting us on hold. There's going to be a post-webinar evaluation that I'll send out on Monday. We are recording this conversation for replay, and we will have a link to this recording posted on the website on Monday. Clemens Steinbach is our director, and he actually regrets that he's not able to join us today. He was prepared to join us yesterday, but he's out on a site visit today. So on Clemens' behalf, I'd like to warmly welcome you on behalf of the National Quality Center. Disparities is one of the big issues that remains, and with all of the work that we've been doing over many years in HIV to improve health outcomes for all, we have a segment of the population that, you know, we've had a hard time engaging and achieving viral suppression. And when we look at the data closely and drill down, we find that there's a number of groups who we haven't served well altogether. And so thank you very much for joining us in our journey around ending disparities. I'm going to go ahead and mute this line. All right. Thank you for joining our journey as we try to end disparities and to look at these populations in greater detail. For those of you who I've been muting, you'll see that there is an orange button to the right of your name. You can press that to unmute yourself, or if you'd like to mute yourself, you can press that button to mute yourself at any time. For those of you who are less familiar with what the End Disparities Exchange is and what we're doing together, we are putting together a 9-month initiative that promotes the application of improvement interventions for 4 key subpopulations. So as I said before, we know from drilling down our data in our various sites around the country, each clinic in each region has different folks that it's looking at. But to help us frame this discussion and to think about disparities, we wanted to focus on trans folks, MSM of color, African American, Latino women, and youth aged 13 to 24. And we want to engage all of you in the discussion to create a community of learners. So at the end of today's webinar, we'll talk about some of our upcoming events that we have for future population focus and sustaining and disseminating our work. The End Disparities Learning Exchange is just one part of what the NQC community does for folks. And the National Quality Center has a number of resources from informal things that you can access at your convenience, like the Quality Academy, to one-on-one coaching and technical assistance. We also offer a range of 3-day trainings. And then we have communities of learning like this one, and collaboratives that we run with our federal partners from time to time. If you'd like information on any of our programs, you can email me, michael@nationalqualitycenter.org, or you can visit our website, nationalqualitycenter.org. Oh, and sorry about this. This is not the right slide, but what we're doing today is welcoming folks, and we're going to talk about MSM of Color Health. We're going to be talking about some of the issues that are specific to MSM of Color, and we're going to talk about how we can help to potentially build more leadership capacity among MSM of Color living with HIV. For learning objectives, we want to describe the connection between trauma, HIV, and healthcare access, which are issues that are really key to MSM of Color population. And we want to list 3 suggestions that people with HIV can make to their health providers to increase confidence and ability to do self-care. And then we want to explain general expectations members of the MSM of Color community have of their encounters with HIV programs. Because a lot of times we don't necessarily think about, you know, what individuals who are seeking health care are expecting, but when you think about it, when you think about your own health care and the journey that you have through your own life, you have expectations too. So I think it's a key thing to ask and to consider, what are the expectations of the MSM of Color community, so that we can have a conversation about how we can serve them well and equitably. So at this time, I'd like to turn it over to my colleague, Dolores Dockery. Dolores has been one of our main colleagues and coaches with the National Quality Center for quite some time, and she's been heavily involved in a number of HIV-related policy projects and steering at both the national level and especially the international level. So I'm really excited that Dolores is here to help us walk through this conversation today and to interact with us. And without further ado, Dolores.
Thank you. I hope everybody can hear me. Webinars are always so interesting. I'm never sure if everybody is hearing. Thank you, Michael, for introducing me, and I'm really excited about this round table discussion that we're having on MSM, Men of Color Health. So we're going to start with our stories, and the first participant will be Amir Simon, and I want to allow Amir as much time as possible to talk about our story. Now, we had a previous webinar, and some phenomenal discussions came out of that, and we will explore those further in our question and answer session. But I really did want to now give the floor to Amir to really talk about his story and his perspective. Amir?
Hi, Dolores. Hi, everyone.
Hi.
Hello.
Hello.
Well, my name is Amir. I currently live in Philadelphia. I've always been interested in this field of human services, but I didn't really know what I specifically wanted to do. I was diagnosed with HIV almost 4.5 years now, and once I was diagnosed, that really sparked the interest and led me into this direction. I am currently finishing up school right now. I'm in my last semester. I'm interning at Action Wellness in the case management department, and I'm working with a lot of individuals with HIV and just different chronic illness. I really enjoy it. I really love advocating for the underserved, underprivileged individuals. Yeah.
So what are some of the issues, Amir, that you would like to put forward? I know in our previous discussion you talked about access to affordable health care for MSM, Could you explore that more with us?
Well, a lot of the guys that I've spoken to, a lot of their health care doesn't cover the services that they require for HIV-related services. So it's kind of hard for them to get into care and be able to afford it. I have a friend who actually lives in Texas. He just moved there, and it's been very difficult for him to see a provider because of his insurance. And before he moved, he was on medication, and once he got to Texas, it was kind of difficult for him to get his meds. So he's been off meds for like maybe 2 months, and it's been very trying for him to, see a provider and get back with medication.
Wow. Any other example you wanted to add?
Like just a lot of the clients that I see coming into where I intern, like the health care that they have it looks good, and they have the right coverage, but it's just those key components that are missing due to employment or just not knowing where to go, having the resources, things like that.
Yeah, and Amir, that this is so interesting because when we think about disparities, we're more than 30 years in this epidemic, and sometimes we feel, especially being around as long as I've been, that we've conquered or we've addressed a lot of these issues. But what you raise is knowledge and the fact that there needs to be ongoing education to the population, especially newly diagnosed for folks coming into the system. And yes, the issue of employment and insurance are continuing barriers that we need to address. I know one of the issues you also raised before, and I just want to put it on the table before I open up the conversation, is the issue of the need for diversity in healthcare providers. And I just wondered if you wanted to explore that a bit more also.
Yes, definitely. Diversity is actually one of the major issues that a lot of the clients experience. When they, go to their healthcare providers, they want to, of course, be, have some things that they have in common. They want to be relatable, and it makes the conversation that they have with the provider easier to have, because it's not like, well, if they go to a provider and, they can't really identify with them, it will be hard to, really just express their needs because, it might be misconstrued or not understood just in total. That's one of the major things.
Yeah, that's an excellent point. Excellent point. I wanna thank you for just raising those issues. One of the other issues that came out of the discussion, and I would like to hear your opinion on it, was the issue of involving peers in the service delivery. And kind of what are your thoughts on that issue?
I would just say, like, providers can just, get to know the client as a whole before they decide to come up with a treatment plan and, starting medication. Because sometimes HIV isn't the only issue that they're experiencing. So just getting to know them as a whole, listening more, just really using your effective listening and communication skills.
Excellent. Yeah, I agree. I want to ask people on the phone, what are your reactions to some of the issues that Amir raised? And kind of what are your thoughts about some of these issues? And you're also free to raise other issues. I'm going to ask Michael to take folks off mute so that they can respond.
Absolutely. Okay, so I'm unmuting folks right now. You know, and while I'm unmuting, while I'm unmuting folks, one of the things I'd like to ask Amir too is, you know, especially you're a young man yourself, and you've worked with folks in your role in the Children's Hospital there in Philadelphia. Are there any issues specific to young men of color, and especially young black men, that you'd like to raise and put out there for folks to discuss and think about?
Just like these misconceptions that we've all experienced, you know, being over-sexualized, you know, some of the pointless materialism, some of those kind of like getting away sometimes.
So the generalization stuff, it's good to have a good sense of what are real issues, but we need to make sure, like, what is in the realm of a real issue and what might be a stereotype. And I think that probably resonates with quite a few folks in the line, you know, not only within our service roles that we provide, but probably even within our own lives. I know that, you know, I've been definitely stereotyped or, you know, kind of put in a bucket just because I'm a gay man. And, you know, as a white gay man, that's different than what other additional baggage and stuff that folks have to deal with, considering other identities that they have.
So everybody, your lines are now on mute, so we would really like to hear your thoughts on the subject that we've been discussing so far.
Hello, this is Cedric. Can y'all hear me?
Hey, Cedric. Yes, we can hear you. It's a little muffled, but we can definitely hear you. Thanks for joining us.
Okay, no problem. I like to agree with Amir, because I hope I said it right. But, yeah, I think we do have to look at the issue a lot more holistically, especially here in Jackson. You know, we're trying to empower our young black gay men by helping them in other areas in their life, like, you know, if they don't have a job, what we can do to kind of help them to get a job, help them to learn how to do resumes, or also help them to know what they need to do for the interviews, as well as housing. Of course, housing is a big issue, and the family dynamics. So we're basically trying to work on those issues first, and foremost, of course, you know, issue we want to say that they're HIV positive or HIV negative, and make sure that they take care of themselves. A lot of the issues dealing with stressful issues like homelessness and trying to find a job, especially in the economy here in Mississippi, and also trying to deal with the fact of rejection from the family. So I think that's some of the things that we're working on here.
Cedric, I am so glad that we're finally able to connect with you. You are listed as one of our speakers, and the points that you have raised around the need for holistic service to this nation I think is the crux of the matter. The issue is that it's not just HIV, but it's all the other things that impact a person's life. As you've mentioned, you know, job and housing and skills that young people need so that they can get those jobs. What I would like to do is to give you space to raise some of the other issues that you think are important, the health to MSM's health, and I want to give you that space to do that now.
And we'll come back to you, Joey. We'll come back to you, Joey.
Okay. Some of the other issues that I think is important to MSM health, for one, I think mental health is important, basically, for MSM health. Support, especially for those that are HIV positive, to have support from not only you know, from their family, but also from the community, because we have a lot that get the medicine, and because of lack of support or because of fear, they don't take their medicine. Another issue, I think, and maybe important to their health, is transportation, because the lack of transportation.
Cedric, we lost some of what you said, so I'm going to ask you to speak because there's background noise on the phone. So if you could please.
What I'll do is I'm gonna mute all lines, and then I'm gonna go ahead and I'll unmute Cedric and Dolores. Hold on just one moment. Silence. Okay, Dolores, you were unmuted, and Cedric.
So if you could repeat, Cedric, you talked about the importance of mental health. So if you could just start from that point again.
Okay, I said as far as other issues dealing with Black MSM's health, I said mental health. I think that's something that we need to look at as well. When we talk to a lot of these guys, there are some issues as far as growing up, family issues, or some dramatic thing that may have happened in their lives, and they don't really want to talk about it, and it actually mentally it drains them. And they get the feeling of nobody really cares anyway, so why should I be concerned about my health? Another factor, I think, in dealing with the health is transportation to get to the their provider, you know, and also one big issue that I think in dealing with their health, and as you know, we can go back to history, to Tuskegee time, where men just don't like to go to a doctor, period. So they wait a long period of time before they actually go. I have a friend now in Memphis who is getting very sick, who hadn't taken an HIV test since 2010. And finally, his partner convinced him to take a test. So now, you know, he begins to lose weight, so he may be an AIDS diagnosis now. So it's just the fact, the fear of, you know, going to the doctors and all of that.
Wow. And I know that is very real. What are some of the things you're doing where you are to address some of these issues?
Okay, well, I actually just started a new job. And what we're doing, we're opening up a place called The Spot, which stands for Safe Place Over Time. And The Spot is going to offer to our community a place for the guys to come to. We're going to teach them how to make a resume. We're going to have job training skills. We've collaborated with one of the WIN Job Center here to come in and have little sessions with the guys. We have collaborated with someone who's going to donate clothes. So we can teach them how to dress when they go on these jobs thing. We've got a barber that's going to be here to kind of groom them up right. We're going to have different sessions each week, like a movie night, around a circle night where you can talk or whatever. They can come here. We're going to have them to, if those that are draw, you know, have that can draw whatever they want to come draw with, we're going to do that and let them post that up. We got a space that if they want to come dance or practice on their routine, they can also do that. We collaborated with counselors in the area. So if we need someone to come and actually sit down and talk with the counselor, we can do that. And basically the spot is for them, a safe place for them to come over time to holistically look at their health and kind of, you know, if they just want to get away, if they just want to come and sit and watch television, that's what this would be for.
Wow. Thank you for sharing that. Thank you, and I'm sure Micah will follow up with you to get, if you have a website or a link that you can share with us. That will be phenomenal. I hear that Joey is on the line. I want to thank you very much, Cedric. And just before I open it up, I want to allow all the invited presenters to speak first in the interest of time, and then I'll open it up for all of us to have dialogue and discussion. So Joey, now that you're on the line, I'm going to ask Michael to unmute you so that we can hear more of your story and hear more of what's going on where you are.
Joey, you are unmuted. Go ahead, sir.
Okay, how are you? How's everyone?
Very well. How are you?
Welcome, Joey. Please go ahead.
Okay. Hold on one second. I'm walking somewhere.
Did we lose Joey?
No, I'm here.
Oh, good. Well, Joey, when you were on before, when we were discussing the issues, one of the things you raised was that you saw the importance of peer involvement in MSM health. And I really wanted you to express some more. So I don't know if that's a good starting point for you.
Yes, my experience here in the Puerto Rico Department of Health has been based on giving talks and workshops to patients, identifying myself as an HIV-positive person from the beginning. And that immediately makes them more receptive to the information I'm giving them, and they feel much more comfortable talking about their problems and insecurities. Whereas I've been in other settings with psychologists and social workers, and the dynamic is not the same. They can be present, but having somebody who's identified as HIV positive giving the workshop really makes a huge difference.
And I think that also helps in how people access information, and I know that was one of the issues you explained a little bit, and I would love you to kind of expand on that discussion, especially as you see how peers can play a role in providing information.
Well, one of the things is talking to patients in the clinics and sort of give them like a small train of trainers so that they can approach other patients that attend the same places, be it the same support groups, the same clinics, or the same pharmacies, and that they can talk to them about adherence to treatment. Because one of the biggest problems we're having is low adherence and high viral loads. And that way, they can give each other support to remind them to take their medicines, remind them to go to have their blood work done and go to the doctor. And it works very well because they work like friends.
And do you so where you are, what are some of the efforts that are being made to address high viral load?
Well, I'm the only one giving talks. So I run all over the country giving talks. I go to all the clinics every 3 months or so. I visit each and every one of them. And I give talks to the patients that are in the waiting room. And it works pretty well. When I go to the clinics, as a matter of fact, today I couldn't go because I had a meeting here. There's a full-day workshop being given to new diagnosis and low adherence patients. And it's an all-day workshop with different speakers. And that's one of the efforts that we do. And those happen once a year in 4 different places in the island. But when I go to the clinics, sometimes I have patients that come up to me and they say, "Thank you, Joe, you've changed my life. I now take my medicine every day, and I have an undetectable viral load."
Wow, that's
so those talks really, the talks really work from the perspective of another HIV positive person. Last year, I gave talks to 78 patients that had high viral loads, and of those, 64 suppressed their viral load within 6 months.
Excellent.
Anything else?
To share with us, Joey?
I'm sorry?
I wondered if there was any other issues that you would like to share with us.
Well, I think that here in Puerto Rico, and also it's probably the same in the United States, access to health care has a lot to do with social background, the community where the people come from, their race, their education level. White men in the United States, gay men in the United States, have much better access to health care than minority populations. And I've experienced it here, that there's a lot of biases and prejudices from the medical staff towards people who are transgender, who are black, who are poor, who are homeless, who have little education, and then the other patients that are white have a good education and they speak like they're educated. They get much better treatment.
And how are you, or what are some of the things that we can put in place to address some of these biases and prejudice? What are your thoughts on how we can address the issues?
Well, I did a workshop which I would be happy to share. That is on sensibility. It's a sensibility training for medical staff, for doctors and nurses. And it's an hour and a half to 2 hours long, and it addresses the sensibility of human beings. And it goes straight to the point of touching the people who are taking it. And the workshop is good because it achieves that the medical staff put themselves in the shoes of the people that they're prejudiced against. So it's really effective. And I think that's one of the things that can be done in the clinics with the medical staff, is giving sensibility training towards all the different populations.
Thank you very much. Thank you, Joey.
My pleasure.
So, Michael, I'd like to open the discussion with the larger group.
Absolutely. So here we go. Our speakers are all unmuted. And as I noted before, if you look at the participants list, you can find your name and you can press the orange button to the right of your name to unmute your line. And I think to get us going, I want to just kind of go through what some of the items that have been included in the chat room so far include. We have one question from Robert in Florida. He said, do the panelists have difficulties with the multitude of appointments and the many medications as a barrier? So I think that this is something that he's asking a little bit about your experience, but also the experience that you have in speaking with folks that you work with in your various capacities. So, you know, all of the different appointments folks have and then the medications, is that something that's a challenge for folks? Well, don't all speak at once. I don't know if maybe, Amir, if you wanted to make a comment on that first. I know that you work mostly with young folks, as does Cedric, so maybe we can think about it that way. Either Amir or Cedric, if you could speak with your experience dealing with younger folks, or, you know, like if appointment management and medication management is a challenge.
Hey, Michael.
Hey.
Yes, definitely. Like having the you know, multiple appointments on different days and different locations, it is definitely a challenge for some of the guys that I've spoken with, because, you know, they have to request off work, they have to travel from this location to this location, and actually one of the clients, they suggested that they would have all of their appointments on one specific day and have everything just in one location. You know, one-stop shop, make it easier, more convenient for them.
That's excellent. You know, one thing that I'd like to kind of throw out for all of us to think about, I know that when I worked in Massachusetts and also when I worked in D.C., one of the challenges around one-stop shopping is in terms of, you know, from an operational and financial standpoint for a clinic or an ASO, like if they're going to be billing insurance, if they're going to be trying to, you know, engage a third-party billing system, usually there's a limitation on the number of services that you can access one day, and Medicaid in particular is notoriously guilty of having those types of limits. And I'm wondering if anyone on the line has any solutions that they'd like to share in terms of how you get around some of those issues, because, you know, routinely I hear that as a solution that comes from the community. Can you make my life easier by making me only have to come here once? Thank you. The shy crowd today. All right. Just something to think about, you know, as well. Like sometimes there are structural barriers to the solutions, and that's not to say that we should stop pursuing that solution. We just need to put on our thinking cap, maybe twist it to the side a little bit to think, you know, to recalibrate our approach. Another comment that came from the chat room is in agreement with what a lot of folks have been saying about the type of peer service or peer interaction that's really important, that when folks have shared experience or when you can kind of look at each other or have a sense from the way that you're speaking and sharing your shared life experience that there is that connection, that sometimes that really helps.
Hey, Michael.
Yes.
Can you guys hear me? It's Tasha Traylor.
Hey, Tasha.
Hey, I just wanted to add on the topic of navigating the system, especially for young people. It's definitely difficult because, well, take into consideration that even if you took HIV out of the equation, the medical care, the medical arena, it's very daunting, and so it's very overwhelming. And one of the things that we're doing here at Harris County in Houston, we're looking at a pilot program, an outreach program to sort of peer partner, if you will, or have like a mentor, someone who's a seasoned individual who's been dealing with HIV, who's navigated the system, to sort of, you know, softly transition that youth because, again, they're dealing with so much hormones racing, new to care. So just educating them on the system and the fact that, you know, it will take some time. But if we can engage them and sort of keep them, you know, 2 weeks for a youth is like a year for some of our older persons like myself, you know. So time is very different when you're talking to younger people. They, you know, you tell them a long time, they're thinking a month. A long time to us could be 5 years or so. So we have to think in terms of, you know, that youth lens and kind of put on that cap. And then when you add the other layers, such as the intersections of race, ethnicity, culture, stigma, all of that, especially here in the Bible Belt where I am in Houston, Texas, you know, it's really looked upon very differently, and so some of the norms and mores are still out there. So just really thinking about that and the landscape that we're sort of currently looking at with ACA. We don't know really where it's going. So these are some of the tasks that I think many of us will find ourselves in trying to really navigate and maneuver within the next few months. So it's definitely an issue. You know, I do like the safe haven that the other individual, and I'm sorry, who mentioned, I think it was Cedric, the spot. That sounds awesome. We might have to piggyback on something like that. That's something that was done years ago. I know, and I just think, you know, it's so funny. We talked about technology at the beginning of the call. Well, we have to think that's really where the youth are. They are texting, they're on social media. So a lot of what we were doing 30 years ago, it's just not applicable today. So we kind of have to change our way of thinking, and really sort of a paradigm shift, if you will. So thanks.
And this is Dolores. I want to also add that in addition to those suggestions, there is still a value in intensive case management. Really being there to literally walk somebody to their first appointment or to their lab to do their labs, if that is what is warranted. Because I do think that people who are newly diagnosed or new to the system really need a little bit of hand-holding before they get used to the system.
Hello?
Yes, please go ahead.
Yes, this is Kelly, and I have a coworker with me,
Vilma Gore.
Yes, and we are community
health workers.
And Vilma wanted to piggyback on your comment, Dolores.
Yeah, Dolores, when you were talking as far as we were speaking about case management, we do non-medical case management, and these are the services, the supportive services that are needed. For example, what we've discussed as far as housing, what do you call this, employment, and other resources. And yes, I do agree with you. And the nurses with the medical case management already go through so much in trying to get them. And we as case managers or non-medical case managers are able to be there to guide them and help, and help them along the way and monitor pretty much and coordinate whether they are in compliance with the clinical, with the clinical needs that they that are required in order for them to be self-sustainable. So just thought we'd add.
No, I agree with you totally. And then to Joey's points and Joey's discussion around peer. In where you are, is that a necessity or is that an opportunity that exists where peers could also be a part of that navigation and intensive case management situation, or is that something that's not needed? I would love to hear your opinion on that.
I really think that it's very vital to have somebody who's going through the same thing, the same challenges, be there with you to support. I mean, like always attract likes and so forth. And just like what Joey was saying, the success has been tremendous because of you, like, as young, I can imagine as young people who are suffering HIV, saying, hey, how are you doing? Just being there, being part of that group, and it's always that belonging that they need. And having that partner or that peer support is, I think, vital.
The opportunity, this is Kelly, I'm Kelly, the opportunity for community health workers here in Las Vegas and even in rural areas is really starting to grow. They're starting to see the need of peer-to-peer, especially with the chronic disease, and that's how I approach it, and we approach it, especially with young people, is that it's a chronic disease. And so try to get away from the stigma. But as community health workers, we really like to do that intensive basic hand-holding and guide them through the process and then pair them up with a peer model that can, again, take them further if they need other services, especially also, as Cedric was, I believe it was Cedric with the mental health. That's a big thread that we're trying to do as community health workers. And we're seeing the need, it's starting to grow. It's very in the infant stages here in Las Vegas. But it is starting to grow, and it's very exciting. We're very excited about it.
And thank you so much, Billy, and your colleague. I didn't get your name. I'm sorry. But thank you.
Vilma Gore.
What did you say your name was?
Vilma Gore.
Ah, Vilma. Thank you so very much for sharing that.
Hello.
I saw that Randall had a comment. I don't know if he wanted to speak and address those comments now.
I see that, Francis. Francis, you have your hand up as well. So we'll come back to you as soon as Randall's done. I'm sorry about that, Francis. We're trying to manage all the great comments.
Thank you, Michael.
Randall,
okay,
go ahead.
sorry about that. I was trying to get myself unmuted. What we're seeing now is, even though two of the major cities here declared themselves safe havens, a couple weeks ago they just started the deportation raids. So they've now started placing agents at the hospitals, the courts, major health clinics. And, they're not just questioning the immigrants. If you're a person of color, you have a good chance of being questioned as you enter the clinic. So, it's starting a lot of fear for people, especially in our rural communities, to want to get out and see the doctors. And, it's starting to prove to be a bit of a huge barrier. So, we're, trying to ensure and figure out how to overcome this, but it's, the raids were started pretty secretly. So
yeah, it's definitely challenging. Like the mobile clinics, or some of those other, outreach solutions. I don't know if anyone's pursued any of those or has considered that. I mean, this is stuff that we've been hearing on the news all over the place. I mean, even in New York, the news is saying, that folks that are trying to help, violence against undocumented women, for example, women who gather on street corners waiting for someone wealthy to come pick them up to clean their house, and the abuse and the horrible things that can happen to these women, especially in this environment right now. How do we help folks? How do we help these guys, who are afraid to come to clinic when there's all of this environment about deportation and immigration and racism? Now, I mean, folks, as you were saying, Randall, might not even be from, another country. They may have been born here, and they may not even be of Hispanic, ancestry, and yet all of this racism is being applied to them anyway, and that's really uncomfortable, and they're being questioned about their health and why are you here, and blah.
Right, yeah, and it's true. I mean, and we're going, and kind of on top of that, we're going through a change of our driver's license to be in compliance with, the new rules of the country. So, at one point, I had to start carrying a passport with me to verify that my license was actually an American license, which is kind of a pain in the ass.
Minnesotans have that in many other states too, yeah.
Yeah, and it really now is starting to increase the the stigma fear, because now it's just not there's one thing to deal with being HIV positive, but then to add everything else on top of it, and there's a lot bit of hate being stirred out there. So it plays a huge effect, especially, like I said, in our rural communities. And the other thing I was going to say real quick, what we're noticing here is, we're having a huge shortage of infectious disease doctors. We have great medical care, but they're having a problem hiring new doctors to meet the increase of people that we're starting to see. So, that was one of the big complaints of doctors when I spoke with them last week, was there are points where they're starting not to accept so many new patients because there's a shortage of doctors.
So, Randall, are you seeing where there are more primary care physicians who are providing HIV care?
there is more primary care physicians providing the care, but not providing it very well. I mean, I could go with a big, you know, maybe Michael caught up on some on my Facebook stuff where I had a health issue last year because primary care diagnosed it wrong. Because I was undetectable, they assumed I would be fine, and it allowed a secondary infection to develop that took a year to pretty much recover from. You know, so we're having physicians that don't have the knowledge of HIV care and grouping everybody back into that. Okay, you're taking your medication, you're undetectable. Oh, you're fine. Go on. You know, move down the line.
Great. So, Francis, I think you were next with your hand up. Go ahead.
Yeah, I actually just wanted to let you know what we were doing here in Nevada, and I just wanted to really say, Amir, communication is our key. As far as anyone who is working with people, you have to listen to people. And there are so many different things that are the same, which is homelessness and unemployment and transportation issues, what's happening with the Affordable Care Act, what's happening with all of the care providers. I think that there's a low tone universal. It's the same everywhere that we are looking. But what we can do is, I think it's critical that we really seriously, viral suppression is our key. We do have Brian White. We do have individuals who are in care that are trying very hard to make sure that the calls are made, people are at their appointments, transportation, bus tickets, vouchers, things that are needed. But I think more so than ever, I think that disparities are the same in so many places. But I also really feel that people have got to listen to people, and that is uncovering the global piece of healthcare. And we can't go forward without that. So that's all I had to say.
Excellent point, Francis. Excellent.
Thank you.
Michael?
Yes, so I see that Linda has her hand up next, and then John. So I have unmuted Linda. Go ahead, Linda Trujillo.
My question is, and it's really more of a statement, I'm disturbed by the gentleman in Colorado who was on meds and now has been off meds for 2 months because he can't get into care or he can't afford it because of his insurance. And with Brian White and with being able to suppress the viral load with the medications and stop the spread of the disease, how is that a priority? How is he, I mean, why, you know what I mean? I don't understand that. Why is it still that hard for them to get meds? And that's the other kind of question I have too, is that people who are maybe on access and aren't working and are plugged into programs where they can get their medications free, is that a problem for those who are working and then fall off of access and have to pay for their medications, and their insurance may not cover it or cover all of it? Those are my questions.
Those are definitely excellent questions and concerns. I don't know if you know, anyone on the line has you know, any solutions that they've done, like in their own work within their city or state, or if your agency's been doing any work within communities or to help the city or the state to kind of manage these problems. I feel as though a lot of these issues end up being pretty local, you know, and I'd be really interested to hear what others have to say who have faced this problem and tackled it.
I think I have to agree with you, Michael, that a lot of these situations are local. I know where we are. If, for instance, a lot of folks do not renew their insurance in time, so there is a lag between when their insurance expire and when they need to get back onto their insurance. But where I am in New Jersey, what we're able to do is reach out to ADAP to fill that gap. I think there are two factors at play, is sometimes our clients don't have the information or don't know where the resources are, and that's where the strength of a case manager comes in to help them to navigate the system. And then, yes, if your insurance lapses for any reason, there is a lag time before you can get on to the next policy, but oftentimes there might be wraparound services that you can access to help. And of course, I'm not where this situation is, so the local situation might be different, but I'd love to hear what others also have to say.
This is Frances Dolores, and yes, you're absolutely right. ADAP is there, and because of the fact that this is in every state, I've got the same question, and I also chimed into hearing that disparity and why is that person off of medication, and what can we do to help them?
Great. You know, I'm seeing some comments come in privately, and I know that folks are talking about getting the emergency rooms and other folks involved in terms of like helping to, you know, provide a quick HIV test, if that would be something that would be supportive. And, you know, challenges with that are that the hospital might say that it is too costly, and there's a lot of activity in the chat room right now. One thing that I wanted to do, I think David had his hand up, but since John put his hand up first, I'm going to go ahead and unmute John and then David. And we only have about 4 minutes left. So John, you're unmuted. Go ahead, sir.
Yeah, thank you. You know, we're talking about young MSM coming in and maybe being newly diagnosed. But I'll tell you, I find the biggest issues are the transitions from pediatrics into the adult clinic. Even though they've been all their life taking medicines and been involved, for them it's a really big change for them. Yeah. And even though they've been through this and dealing with it, it's a whole new world for them. And for some reason, they seem to separate themselves. And they start not wanting to take their medicines, not make appointments, and things like that there. So for me, talking with the peers, that's an issue, trying to get them to understand if nothing's really changed, it's just a progression from being really young into the adulthood situation.
Thanks for that. Thanks for that comment. And I have now unmuted David. You are free to go, sir.
Hi, Michael and Dolores. How are you? I'm glad you're doing this.
It's great to hear your voice.
Thank you. I wanted to go back to the topic of MSM of color specifically, because I think that some of the problems lie in maybe some of the stereotypes surrounding the substance use and mental health. I know specifically in New York, it's very hard to find a mental health provider that looks like me or people of color. And I think that sometimes is a barrier to some men of color coming out and talking about personal issues that may have to deal with race or even more personal topics that they feel they can't talk to someone outside of someone who looks like them. But I did want to address and I'm sure you all know, and everyone's informed about trauma experienced patients and adverse childhood experience, the ACE. But I think that's a very important topic that providers need to look at, because there's a doctor in the San Francisco area, Dr. Nadine Burke-Harris, that has done a study about adverse childhood trauma and how it, when happening in the developmental phases of childhood, it lessens your development, and then later on in life, you're more inclined to have other ailments. Your body has never developed fully because maybe you've been in a domestic violence situation or a parent who's using substance, and you're not fully developed, and your body's not fully developed, the brain, the systems of the body. But I think there's disparity in the number of adverse experiences that men of color have. You know, they're targeted in so many ways. As you can tell, the prison systems are overloaded with them. But that's one of the areas I think providers can be a little bit more in tune and aware of. We talked about providers getting people retained in care. I think it happens to me far too often that my appointments are canceled. Then I have to remake an appointment. So, you know, you think about how much it takes to make an appointment, to dedicate the time, and sometimes it's hours on end. They don't take you right away. But then if you aren't informed that your appointment is canceled, then that leaves a bad taste in your mouth and whether or not you want to go back to that situation. Last point, men of color, older men of color. I've been 30 years being diagnosed. God bless, I am here. But
Amen.
Notice, yes, definitely. This year makes 30. But as we get older, men tend to isolate. They're not connecting with the community. And the services aren't necessarily geared toward MSM of color who are elderly or older. I like to take on the title of elderly, but you know, but I'm just saying, okay. So I think that's another area we could look at, and then including patients on the quality management teams at the facilities where they're providing services. So you actually have a consumer in those meetings that are you hearing directly from. And I'll stop there.
Wow. You know, David, I always love talking to you because I think that, you know, you have such, you know, a great perspective on this. And I love the way, you know, you're part of this community, but even when we talk about folks who, you know, are outside of, you know, personal experience, like you're so great at breaking things down in that way. So, you know, considering we are short on time, oh, no, thank you, sir. Considering we're short on time, I don't know if we have time for a Q&A session, but we did have quite a few awesome things that were shared on the line today. So let me recap. We just heard at the beginning, Cedric talking about the spot and some of the work that they're doing down in Jackson. And I think that it's great to think about, you know, a program in the South that is really geared toward MSM of color, you know, and how we might be able to apply that to our own setting if we're from like a more rural or a more southern setting, or even if we're up north. I think that there's a lot of parallels there and a lot of lessons learned. So I'm going to reach out to Cedric to make sure that we can include some of those materials in a packet on our website along with this recording. In addition, I'm going to reach out to Joey and Amir to talk a little bit more, maybe provide some bullets around some of the things that they've done too, just kind of like a quick checklist in terms of stuff that you may have thought of. And I'm going to reach out to folks that I've seen on the chat room here in terms of some of the items that they have mentioned. In particular, David, I think that some of David's points were really important in terms of thinking about, you know, what we need to keep in mind. And, you know, in general, as we get older, I think a lot of the HIV service system isn't really well equipped and they, you know, to deal with older folks in general. And when we get down toward, when we're talking about sexual orientation, we're talking about race, and, you know, especially the intersection of these things, you know, there's a huge need there. And I think that it'll be interesting to see how that discussion can kind of like roll out as we think about this more and more and more as an entire national Ryan White HIV/AIDS program community and how we can all help each other to serve our patients as best we can. Just a reminder, because I had said that we were going to do this. This is a Partners in Care discussion is on MSM of color, but next month, March 23rd, we have African American and Latina women health. Really excited for that discussion and the lineup we have for you on that. And April 27th, youth, age 13 to 24. Another great conversation. We'll have our spokesperson folks there, in addition to some other community folks who are active in serving these communities on the line. Of course, we'll talk about sustaining our gains and disseminating our work later as well. Of course, we also have our main webinars, which are 90 minutes that'll focus on each of these issues. Again, we usually have our webinars the third Thursday and our Partners in Care roundtable the fourth Thursday. And when you see this online, each of these is a clickable link so that you can just be taken right to the page where the webinars live. Our next office hour is actually rescheduled from today. It's going to be on March 3rd. If you check the website and then our Facebook, we already have those updated as well. We're going to have a focus group with Debbie Sestaro-Seifer, who is also on the line, to help us think through some of the discussion that we had today, and kind of bring that out further and kind of pick up some of these threads, like what can we do, you know, as consumers in particular, to help advocate for ourselves and to, you know, kind of advocate for the others in our community, especially from the MSM of Color standpoint. And, you know, just the last thing that I want to say is thank you very much, again, everyone, for joining us today and for understanding that we had that technical hiccup yesterday. We started a little bit late, but we were able to, you know, kind of keep this within an hour. And it's really great to see so many folks still on the line. And it was really amazing, the level of community input and discussion that we had this afternoon. So thank you very much from the bottom of my heart for joining us and for being an active participant in today's discussion. It's really important for us all, but in particular the MSM of Color that we're trying to serve, and you know, it means a lot. Thank you.
You're welcome. Thank you.
All right, and thanks to Dolores. Yeah, thanks to Dolores, Cedric, Joey, and Amir for sharing today, and Dolores for doing such a great job facilitating the discussion.
Thank you.
Thank you. You all.
No problem. Thank you.
Have a great day, everyone. Have a beautiful Friday. Stay dry if you're out west, and enjoy the sun if you're back east.
Take care.
Bye.
All right, we'll do.
That's a mess, right?
Cheers.
And how do I get on? Yeah. Cool. That was very cool.